age-old question is this concept in our field of the ivory tower randomized controlled trial. Here's what's established the efficacy of these treatments. We studied it in a very tightly controlled way with a lot of monies put in to support it, with independent evaluators and independent reviewers and taping of sessions, and a lot of resources go in to say, is what this treatment proposes to do actually doing what it says? And then that's efficacy. That's a tightly controlled design study. And then effectiveness is, well, when we take it from the ivory tower, now we implement it in clinic X in this geographical part of the world where we don't have all the resources and we don't have all these people watching. And we say to the average busy clinician, here's a protocol that we think helps with anxiety. We've tested it. We know what it can do on average. Now try it. There's always this, what's called the gap that exists between the rigorously controlled trials of efficacy and the more loosely implemented effectiveness idea, right? What this study did was it said, let's take a peek inside the offices of a large 17,000 visitors or something like that, right? It was huge. So we have this massive data set of what's really going on in the background when there's not a rigorous, it's like, here's the real world. And it starts to say, well, if you take one element of what makes CBT effective, arguably it's that it has a summary at the end of the session. It's not everything. You have to, there's other principles that make CBT different than other talk therapies, but one is certainly arguably, does the therapist and patient do some sort of summary at the end, right? And if we use that as potentially as a proxy for, well, how many people are actually using that component across all of these? How often is that done? Then you can start to say, well, it's a bit, for the trainees, I say, it's like, if you want to make a chocolate cake and you have a recipe for a chocolate cake, and you say, this is the recipe to make this is the top chef's, top baker's chocolate cake. And you say, I'm going to make that chocolate cake, but I don't want to put butter in, and I don't want to put flour in. And I think I don't have any cocoa, so I'll put strawberries instead. And I ran out of eggs. My oven's not working so well. If you put that into the oven, you can't expect the same chocolate cake to get up, right? You can point, that's what stands out in my head. If that's one ingredient that across all these 17,000 sessions, only 0.3% have that one ingredient, you still may end up with it's not enough to say you won't have a chocolate cake. But what if that's a proxy for other things that may be missing? That even though I say I do CBT, am I actually doing CBT when the door closes? That's my take, and that's what's striking about the study. I've never seen one like this in real world, in the back, not part of a randomized controlled trial that just said, not asking therapists to tell us what they do, because I think therapists, I do session summaries, I set agendas, I do but actually looking and peeking in and saying, here's what actually, I have to be, to this day, I have to be very deliberate with my patients about setting following the principles of CBT. So it's more for the people who are struggling to get the outcomes that they'd like, who say they're doing CBT. It's to remind ourselves that there's a deliberate set of procedures that CBT involves, and that there's risks if we deviate from them, and then better. But how do we get people to do more when they're not being watched? And Eleos helps give feedback. If I'm an administrator and I see this, for trainees, I want to say, oh, like, how do we? That's a good supervision topic. How do we make sure that we review the components that would lead to outcomes? You know, we didn't talk about this, but the other thing that this platform does, which I think is one of the real selling points in a busy clinical field, is it condenses the session into an editable progress note, right? Which accurately captures the details of the session. Right? C-suite, if we can reduce burnout in our patients, in our providers, there'll be better quality of life satisfaction. They'll be more productive, and then the time spent that I'm not doing notes, I can address our 6-month backlog of wait lists, because I can free up those hours that I'd be spending writing notes and making progress because I'm being watched and being tweaked on how I treat my patients, so I can start to taper patients who don't need as intensive work. And suddenly I have more space in my schedule to take on more cases. So our wait lists get reduced, our wait time to treatment gets reduced, and then we can bill for those visits, which helps revenue in the system.